here. All right, so welcome everybody to our quarterly VCSQI Quality Committee meeting. Thanks all for being with us here today. Welcome again. We have some STS data primarily to go over this afternoon. So we have our latest and greatest Q4 2021 STS metrics and benchmarks, which we can show off. We have a special set of data from the STS as well that compares COVID patients against non-COVID patients. And as always, feel free to stop us for questions, comments. We really want to make this an open approach. And once we're done with the data, we can open it up for Q&A as well for the group. So if there are no other pieces, let's move forward and jump into some data. So again, these are the Q4 2021 metrics from STS. All 17 of our centers have submitted data through the full calendar year 21. This is our VCSQI strategic plan, mission, vision, and core values. We will start with just a quick look at open heart volumes by quarter. So you notice a pretty good dip in Q2 of 2020, of course, with the initial COVID surge. Things have bounced back, of course, since then, but generally seem just a little bit more variable than usual. There was a bit of a dip in Q4 21, for instance. Next up, we'll look at some data by facility. So these are the measure specifications. We're going to look at rolling 4-quarter periods, so calendar year 20 against calendar year 21 by center, which are then grouped by procedure volume. And we're looking at pretty standard STS metrics here. They are sorted by performance within each group. So the top performers will be on the left within each volume group, and the lower performers on the right side. And of course, these are all coded as we normally do with the hospital level reports. So you can search for your hospital code on the bottom. These first up, we have Interop blood use by hospital. So the overall VCSQI rate was about 17.5%. Compared with STS 2020, the latest benchmark that I have is 25.7. You can see the top performers here, they're around 12, 13% or so in terms of Interop blood. Next up, this is post-op blood, and these are any components, by the way. This is not just RBCs, this is any post-op blood. Last one was any Interop blood. The overall VCSQI rate here is about 23.4% for calendar year 21, compares against 28% for STS. Our top performers are down here, close to 15%, probably a little less than 15%. Next up is a relatively new quality metric that we've started looking at over the last year, which is multiple arterial grafts. So this is either dual IMA or radial plus IMA. And this is starting to trend upward here. We're nearly at 20% across VCSQI. There are 1 or 2 centers that seem like they are kind of leading the charge in this arena. And others are slowly adopting this practice as well. Anyone on the line, are you working on this internally in terms of increasing your MAG usage?
We are not, Eddie. We haven't even given this a thought that I know of.
Okay. Thanks, Tracy. Anyone else?
Yeah, in Winchester, this has been a focus area for Dr. Kofsky, and he's been talking quite a bit about that, sharing some of the literature on it as well. So definitely an area of interest.
Any strategies you all are adopting, Jeff?
We've brought it to our, we've got a coronary heart disease council, and we've had that as a topic of discussion. Nothing really hardwired at this point in that, but more of an area of interest and kind of sharing with the physicians and looking at, MAGs versus, multi vessel stenting and that sort of thing.
Understand. Thank you. Any other questions, comments on our MAG usage? Next up, we will dive into some of the post-operative events. So first up is new onset of AFib. The overall VCSQI rate is just a hair over 21% compared with the latest STS number we have, which is 25.9. And just in tracking the VCSQI data, it seems like we have dropped a couple percentage points for our entire group over the last couple of years. Next up is early extubation. So initial vent times less than 6 hours, or extubation in the operating room after a bit of a dip during the initial COVID surge. Rates are back up to nearly 2/3 of cases with early extubation. The corollary here is prolonged ventilation. This is observed to expected, so a risk-adjusted measure, which applies the STS recalibration coefficients. So the VCSQI average is just a hair above STS here, 1.05 versus 1.0. Renal failure has been a hot topic within VCSQI lately in our AKI work group. You can see this is actually an area of need in that our group's overall OE ratio is nearly 1.25. So as centers adopt our protocol, it'll be interesting to track this and see if we can move the needle a little bit. Anyone on, have you all adopted or at least considered looking at the VCSQI AKI recommendations?
Hey, Eddie, Yuri here, looking at it presently at SRMH.
Thanks, Dr. Zukov. This is NQF reoperation. So any reop for cardiac reasons VCSQI average is right around STS, maybe just a fraction above. And we, of course, we'll send these out later to everyone as well. This is permanent stroke observed to expected. You can see with a small n here, there is a decent amount of variation, which I think is to be expected. But the overall VCSQI rate here is again right around STS. Our last risk adjusted metric is operative mortality observed to expected. You can see in general, VCSQI programs are doing well with an OE of about 0.9. All right, so this is a new measure for our slide deck here. This is failure to rescue, which for those who aren't familiar with how this is calculated, it's based on patients with at least one major complication. So the major complications we just looked at, plus deep sternal wound infection, and then those patients who also incurred operative mortality following one of those complications. I believe STS is starting to look at this measure as well. So we wanted to just see how the data looked within VCSQI. I don't have a STS benchmark for this yet, though. Is this something folks are looking at internally, either via the phase of care mortality analysis or otherwise?
Hey, this is Beth from Mary Washington, and I can tell you that every month Mike goes over in great detail about failure to rescue. So that's something that we cover for our patient population. And it's not just for CABG, though. He covers it for everybody, all of our open hearts.
Thank you, Beth. Anyone else looking at this measure internally? That's something we can definitely keep tracking as one of our newer measures here. Just sort of see how this trends over time here in VCSQI. Up next is an old favorite, our 30-day readmissions by hospital, hovering between 8 and 9%, as we have for the last couple of years. Seems like once COVID hit, that readmission rates have been a little bit lower. It's still a decent amount of variation here between programs. The top practices are actually below 5% readmissions, which is pretty impressive. Is anyone doing anything special here, since COVID started?
Eddie, we do a lot of early follow-up clinic for patients. So we usually get them in day of a call if they need to be seen, or at least within 48 hours. So I think we've seen pretty good stuff from that standpoint of just rapid early follow-up on patients. And we look at that quite frequently.
Thank you, Charles. Here's our average postoperative length of stay. So VCSQI is almost half a day above STS here. This is all comers, so we could also break this out by maybe elective, non-elective, depending on if you all think that would be useful. And last up is median ICU hours by hospital. So a median time to kind of offset some of the potential outliers in the data set. The median time was just under 60 hours across our entire cohort. See, our top practices are around the 30-hour mark here.
I don't know about the other facilities, but with COVID, we've had a terrible time with bed availability. So a lot of our patients are being discharged even from the ICU.
Same here.
Tracy, this is Denise from Norfolk, and I would agree, we did have a hard time with the capacity as well. But Eddie, back to the last slide, I think you asked about post-op length of stay. If you could divide that between electives and urgent, emergent, that was your question?
Yeah, would there be value in kind of slicing that out separately?
I would certainly like to see that. I think that would be very helpful. Thank you.
We can do that. Thank you, Denise. Dr. Sukov, were you asking about the ICU hours slide here?
No, just had a comment that with COVID, the step down unit is a hot commodity.
One question I think that came up is, for our database managers, is this metric counted when the order is written to be discharged from the ICU or when the patient actually leaves the ICU?
Eddie, we measure from the time that perfusion marks their time out of the OR until they are received on the next unit. So those are the units of measure that we use.
Okay. Gotcha. So the bed availability would really come into play there. Makes sense. So those are our standard STS metrics. At the suggestion of our quality committee last month, we also took a look at COVID-19 as it's coded within STS and some comparisons between the COVID and non-COVID populations. So this is just over the last couple years, defined two different buckets here. One just for COVID patients. So this is based on how STS codes it. They have either pre-hospitalization, intra-hospitalization, before surgery, after surgery, and post-hospitalization COVID diagnosis. All of those four categories were combined into one larger group just to create a bigger sample size. This is compared against all the other non-COVID patients. So this is all comers, all STS procedures, not just CABG, but everybody. And looking again at just COVID versus non-COVID. So here's some of the highlights. I did some comparisons for about 60 of the STS fields. These were the ones that looked most interesting in terms of demographics. There are definitely some differences when it comes to race, ethnicity, and age. So COVID patients being less white, younger, and more likely to be Black and Hispanic. These were all statistically significant. In terms of risk factors, COVID patients were more likely to be on dialysis, to have chronic lung disease, home oxygen, and heart failure. Looking at process measures, the incidence of ECMO was about 2.5 times the non-COVID population in the COVID patients. Vent hours, it was not statistically higher, but it still looked like it was trending that way. Creatinine was a little higher post-op, as well as length of stay post-op. And lastly, in terms of post-op events, mortality was similar between the two groups. Sternal wound was higher for COVID patients, as was prolonged vent. Pneumonia was not statistically different, but again, looked like it was starting to trend a little bit higher in the COVID population. So that's just a snapshot of some of the key differences between the two cohorts that I was able to find and tease out. It's hard to say whether this is, correlation, causality. Are the patients sicker going in and then having worse outcomes, or are they sicker because they have COVID, or are they sicker before they got COVID? It's kind of hard to really delineate that. I see Dr. Tiemann's on the line. You have a good eye for research like this. What do you think about that, Nick? Maybe he stepped away for a minute. Any questions, comments, other data points you would like to see as far as COVID correlations?
I think this is very well done, Eddie. I'm sorry we had, well, I shouldn't say I'm sorry. Thankful that we have a smaller group, but I think that may increase a little bit in the next quarter or so. And as well, with all the challenges that we've seen around like length of stay and prolonged vent and all of those things, I think it could be a little bit relative to that. I think people are sicker because they're waiting to come to the hospital and they're postponing their surgeries and such. But overall, I think this is very, very well done, and I appreciate you taking time to do this for us.
You're very welcome, Beth. And we can definitely slice this differently or drill down. I'm sure we'll have a little bit larger cohort too once the Q1 data starts to come in. Any other questions, comments on our original data slides or other measures you all would find helpful with regards to your internal quality efforts. Well, again, we will be sure to send out these slides after the meeting today. And again, hope you all find these useful. And if there's any other data we can provide from VCSQI, please don't hesitate to reach out. Look at that, Sherry's already got the notes here on our agenda.
Yeah, teamwork.
The miracle of technology. So, all right, I think that those were our two main agenda pieces as far as STS data. So at this point, I don't believe we received any FAQs this month. So I believe we are an open forum for the rest of our hour here. We're just about at the bottom of the hour. So any questions, comments, ideas you all would like to bring to the group this afternoon? Yuri, I like your background there.
Slava Ukraini.
Yes, sir. Well, the group is exceptionally quiet today. Are you all enjoying this rainy day we're having? What else is going on out there?
I think it's probably because Judy is not on today.
I thought the same thing. I'm like, we're really missing Judy right now. She carries so much wonderful conversation.
I completely agree. Hi, this is Sam from UVA. I do have a quick question. How can I learn more about the failure to rescue metric? This is really my first time interacting with that one, and I'd love to learn more.
Yeah, great question, Sam. So I can go back to the slide here. So essentially, the way that I calculated this was I looked at two different queries within the database. Do you use ARMIS as far as data entry, or?
I don't. I'm actually one of the program coordinators, so I'm not doing the data entry. I'm just helping to coordinate the programs on the administrative side. Sure thing.
So I guess the best way to think about this would be a Venn diagram. So if you look at think of one circle as being the overall patients who had at least one major complication. So that being renal failure, prolonged vent, stroke, deep sternal wound, reoperation, and there may be one more. The major complications are one circle in that Venn diagram. And then if you do an intersecting circle of operative mortality, you're looking at that intersection between the two. So who had at least one major complication and operative mortality following that complication.
Oh, okay, thank you. Because I was like, failure to rescue, like I missed the Venn. I was missing that Venn diagram piece because I was just like, well, if they, not survive the surgery, then of course that's failure to rescue. But yeah, thanks for explaining that. Now the overlap is the piece I was missing. So that makes total sense. Thank you.
You're welcome. And there are interestingly, a number of cases in STS that are just isolated operative mortalities, so they don't have at least one of the major complications ahead of time. So that's another, maybe another cohort or subset we could drill in on.
Yeah, I bet that would be a really fascinating subset.
Before I went into data management, Samantha, I was trying to get Mike to change the name of that segment of his quality report out to the team. Like, you need to change that. I don't like that. It needs to be something more positive. But then I realized later it was a all apart, and that was why. So I didn't like the name either.
Yeah.
I just realized I have a typo here. We're not looking at 2029. We're not that futuristic yet. So I'll correct that.
I have a general question, Eddie, for the group. How many people in the group are actually using the new soft data fields for like perfusion, going on bypass, coming off bypass, and so forth? There's like 6 new soft fields in ARMIS. So I guess that's a specific to the ARMIS people.
Hey Beth, this is Maggie from VCU. Actually, that was my request. So because we had changed over to Epic and I wasn't getting the cumulative times, so I had to enter some of them. I had to enter in the off bypass, on bypass, stuff like that.
Okay, that makes sense. I was just curious because when we were looking at it, Mike's like, if we start using that, then our times are going to be off. So we want to make sure that we're straight. I just was curious. Thank you, ma'am.
And Mary from UVA says that they are not doing those.
Onset is not, because it's already, it comes up in our perfusion report. And like Beth said, you know, the times might be a little different.
We use what's in perfusion report as well.
Thanks for your question, Beth. Any coding scenarios, any FAQs from STS you would like to go over?
A general question. Did everybody get their report off of IQVIA, and was it correct? I looked at mine just real quickly today, and it looks like my data is not through September like it's supposed to be. It's only through July or through June.
I believe ours was through June 2. I'll have to go back and look at that, but I think that might be a consistent factor.
Yeah, I thought it was supposed to be through September, but because we already got the star rating stuff a while ago.
Can I say something? Or... Hi, Eddie, this is Vicki. Is it okay if I say something?
Oh, of course. Yeah, Vicki, go ahead.
Okay. When you look at your September report, if you scroll down several pages, that's when mine started ending in September. I had to scroll past the star report, and then I saw the September dates. But I had to scroll down at least, I want to say 10 pages or more. And it looks like I have some duplicate pages. But maybe that, I don't know if you guys scroll down all the way.
No,
It's very deceiving. They keep posting the star report at the beginning, and then if you scroll down, you'll see your September data.
Thanks, Vicki. That's interesting that they chose to present it like that.
Yeah, I thought maybe I didn't pay a bill and we didn't get our data because I just took a quick look. Thank you.
Maggie has a comment in the chat box. She just said she was the one who requested ARMIS for the custom fields. So remember, you can customize your data collection form to take those fields off if you're not using them to. They're not required fields.
I have another general question for the group. I have a patient who is transferred out, and we don't have that many get transferred out. And I called or requested records because I figured it would be about time. Turns out that patient's still in-house at the other hospital. And I want to know, do you just, I don't know if we have somebody on here from George Washington. I haven't gone through and combed through to see who might be any participants from there, but I will do that later. As far as the outside records, how they manage that. When you are requesting your outside records, like I was requesting radiology reports, operative reports, all their labs, assessments, as far as the progress notes, consult notes, and death records if applicable. And just in the time that this patient was gone for about, I don't know, close to 2 weeks, we probably got back 3 reams of paper. I want to know if there's a way to refine that. So what do you think?
Beth, we send some patients to UVA and some to VCU. And I wait as long as I can so that I can, the patient can either get better or whatever. I don't personally request, it's my nurse practitioners that request. And I get a lot, most of the time I get, any new op reports. I don't get new labs. I get, the discharge summary. So I have their meds, I have all that. A lot of times in the discharge summary, they go into, any kind of echo or, any of the bigger tests that they have done. I generally don't try to get the little tiny nitty gritty from another hospital just because it's so hard to get anything from another hospital.
I agree, Tracy. It is a challenge, but in order to get the outcomes, I feel like I have to get a lot of that. I guess I don't really need to beat the brush for lab values and the like.
I try to stick with complications. I try to stick with, deaths, obviously. Those are the big things that I really, really want to, those are the things that are in the discharge summary and that sort of thing.
Okay, so with that, do you just utilize your own organization's lab values for those answers? And is it more prudent for me in the future to say, I want your discharge summary, which should have all of that incorporated into it, and then use my own lab values from my own hospital? Is that how you're doing it? And is that, I don't even know if that's okay by STS.
Sorry, I had a phone call come through and messed up my screen. And I stopped listening to you. I'm sorry.
Okay.
What was the question?
I was saying, is it more appropriate for the data managers throughout VCSQI to request the discharge summary, which should have medications or what have you, and death records if applicable, and so forth? That will give you a lot of your answers. Aside from that, do you use your own facility's last lab values? And is that appropriate with the STS?
I have been using my last lab values. But, it's so few and far between. I probably have 2 or 3 a year out of the whole number. I mean, I guess that's a question we can ask. And I know they're going to tell us to try to get the lab values, but it's just so hard to get that sort of thing.
Right, right. I'll field that question, then I'll send it to Eddie, and or I can disperse it. I don't know. Eddie, how do you want me to handle that? Do you want me to send it to you and you send it out?
You're welcome to share it directly if you'd like, Beth. It's
Okay,
totally fine with us.
wonderful. Thank you.
I believe we do have some contacts at GW as well if you need somebody over there, Beth.
That would be wonderful, because I would really love to just call them once in a while and have someone that I know will answer my question. I just need to know if they're still in house, and then I can request the, hopefully not more than another 3 reams of paper. I want to try to minimize what I'm putting into our outside records. And I just want to know how best to do that, because like Tracy said, it's not something we do all the time, but we're required to follow them. So I want to make sure that I'm doing my due diligence. And I would probably change that to outside records, amount of outside records. Yeah. And we'll all have to tell Judy how much we really missed her today.
Yeah, most definitely. I'm sure she would love to hear from everybody. Are there other questions, comments, ideas you all would like to share with the group this afternoon?
I would like to request that maybe we have one more opportunity to go over the aortic section one day with have our senior girls give some instruction on the aorta section, because that's just miserable.
Good idea, Beth. I know Melinda from STS is willing to help us out if we give her a little bit of lead time. So maybe we can schedule a session with her.
That would be great.
Eddie, this is Tracy. I wasn't on the last couple of calls, but the Maryland girls did touch base and want to have a data managers meeting with the 2 states to go over the data. Did you ever bring that up?
We sent out a quick survey to the group, and I think it was about 75 to 80% in favor of doing a joint session.
Okay, who wants to be in charge of that? Because I think I'm willing to give that job up. I've done it for a long time. I think it's time for somebody else to do that.
And we thank you for your leadership and all your efforts, Tracy. It's a good question, actually. Would anyone like to step up, volunteer, either to help out the database managers or as a co-chair of the quality committee, like overall? Don't be shy, y'all. Beth or Maggie?
Eddie, I feel like a position like that needs to be someone who is certainly more seasoned than I am.
That is so not true, Beth. I started when I didn't have all that much experience. You get a lot more experience. You learn a lot doing it. Because, you come a little bit more prepared, and when you organize the conferences, you look stuff up. I think you could do it.
Well, maybe you and I can have a conversation offline, but for right now, I will look to senior bodies for the moment. We'll talk later, Tracy.
Okay.
Well, as Sherry's written here, please feel free to reach out if you're interested in helping out with our quality committee and or database managers. That would be super. And again, thanks, Tracy, for all your efforts over the years.
You're welcome.
All right, at this point, we're almost 10 minutes till top of the hour. I do have a hard out at 4. So are there other questions, comments that you all would like to share today? And if there are none, we can adjourn here. The link that you all used to join this meeting this afternoon for the quality committee, it is the same exact link for tonight's meeting of the main group. Our focus is TBT tonight, so it'll be another kind of one of our focused 2-hour sessions for the main group and the heart team approach toward transcatheter valve cases. So we hope you all will join us tonight, and thanks all for being with us this afternoon and being part of VCSQI.
Thanks,
Thanks,
Eddie.
Eddie.
Thanks, Sherry.
See you later.
Everyone.